This program is brought to you by Ignite TV. Now you're in command. Visit Rogers.com for more details.
Today on Voices of Grey, we are going to explore a topic that has been compared quite a bit to what has happened this year, the Spanish flu pandemic of 1918-1919, and see what efforts Grey County made for infection control over a century ago. Later in the program, we will chat with Grey Bruce Medical Officer of Health, Dr. Ian Arra. As 1918 began, Canadians continued to support the country's First World War effort. After 4 years of fighting, they believed they knew their enemy well. Little did they suspect that a new foe would surface that spring. Between 1918 and 1920, this new villain killed nearly as many Canadians as the war did, an estimated 55,000 in total. The Spanish flu's origins are shrouded in mystery. While theories exist about its origins, scientific study has confirmed that it is a strain of the H1N1 influenza A virus. The 1918 variety earned its nickname due to the First World War. Most European and North American countries blocked reports of the disease, fearing that news of widespread illness would lower soldiers' morale and weaken their war effort. News of the pandemic first surfaced in neutral Spain, where reports highlighted the virus's deadly impact. By the time the pandemic came to an end, approximately 1/3 of the world's people suffered infection, and tens of millions of people around the globe had died. The first wave of the flu reached Canada in the spring of 1918 as wounded soldiers carried it home with them. The first wave acted as most flu infections did, leaving patients with generally mild symptoms. Only those with weakened immune systems suffered significant effects. Once flu season passed, Canadians put the virus out of their minds. As spring turned to summer, somewhere in Europe, the Spanish flu mutated into a more lethal form. In August of 1918, soldiers wounded or reassigned shipped out from Europe, bringing this newer and deadlier form of the flu with them to every corner of the world. By early October, the Spanish flu arrived in Grey County. Newspaper reports still focused on the war, giving only minor attention to the rising pandemic. Few understood the medical threat presented by the disease. The October 10th, 1918 issue of the Owen Sound Advertiser ran an article under the title, "Spanish Flu is Not Serious." The reporter noted that while there were around 30 cases in town, and one should get to bed right away if they notice symptoms, but so far the disease appears to be of a mild type. Combating the flu was a considerable challenge in 1918. There were many obstacles that made it difficult to lessen the pandemic's impact. Powerful microscopes that could see viruses were not invented until the 1930s. Many skilled medical personnel were serving overseas, treating war wounds, and could not study the illness. Wartime censorship made scientific collaboration nearly impossible. Every town and township had its own board of health, and each board made medical decisions independently of other local boards. Lack of a unified response was one of the greatest weaknesses that enabled the flu to spread so quickly and widely. Grey and Bruce County's death count climbed, forcing community response. In the Arra area, which was especially hard hit by the pandemic, the British Hotel was transformed into an emergency hospital. The Owen Sound and Markdale Library's books were ordered to be fumigated. Masks were suggested and in some places mandatory as a means of slowing the spread. Newspapers included instructions on how to make simple homemade versions out of cheesecloth. The local Board of Health requested that anyone with nursing experience or training who would be willing to help treat flu patients to contact the local medical officer of health. The Spanish flu killed more people than any other pandemic in recorded history. In Grey County, more than 100 people died in October 1918 alone. The strain on medical resources, already stretched thin due to the war effort, made for months of sleeplessness for doctors and nurses. Owen Sound's Dr. F.A. Brewster recalled that medical personnel regularly consumed 9 or 10 cups of coffee a day and slept only 2 or 3 hours a night for weeks. While anyone could become ill with the virus, those aged 25 to 45 suffered sickness and death more than anyone else. Because these patients were responsible for children, elderly patients, businesses, and households, the impact was especially high on families and the economy.
Voices of Grey. I'm Stephanie McMullen from Grey Roots Museum and Archives, and I am here today with Dr. Ian Arra from Grey Bruce Public Health. And thank you so much for taking time out of your very, very busy schedule to come and talk to us today.
Thank you for having me.
One of the things that we do at the museum is we look at critical points in history and major events that happened in history and try to learn some lessons from them. One of the things we're doing right now is we're preparing an exhibit on the Spanish flu, which was a very critical event in local and Canadian and indeed international history. But we find ourselves in 2020 in a critical time in history as well. There is a lot that we have learned over the last several months about this viral infection, and I'm sure there's a lot we still have to learn. What are some of the things that over the last 8 months that you've learned about COVID-19 that have challenged you as a doctor?
Wow, those are big questions. Keep people up at night. So the point of peril between the Spanish flu and the COVID-19 is a very appropriate peril. As a matter of fact, COVID-19 is a pandemic of the highest caliber, and the only caliber similar to it would be the Spanish flu at the time, 102 years ago. And both of them are viruses, different families of viruses. However, they have many things in common, and as emergency, they have many things that could be a bit different and interesting from historical point of view and practical point of view. What we learned about COVID is some of it is bread and butter to public health. It's a novel virus. However, viruses and outbreaks behave in a similar way. We're trained in it. And if I may take a little detour, come back to the question, but it's well qualified. In public health preventative medicine is a specialty of 5 years, similar to surgery. During this time, we learn about subjects related to public health, whether it's infectious disease or emergency management, longitudinally over the 5 years, speaking to the media, to the public, how, to face a camera and have that microphone pushed and pressed. All these things are necessary to be able to deliver the emergency response. There are other subjects, whether policy making and how things are run through the parliament to become a health policy and how to be a good advisor. Environmental health, another subject. There are many other subjects. However, if you put these together, they really crystallize into how to manage an emergency of this caliber. Mm-hmm. It's not a simple task just to go and talk to the public about an outbreak, let alone a pandemic, and how to manage it in long-term care in the community. You put it all together, it's a specialty. So when it is all novel to many people, rightly so, it's still bread and butter to the management of these things in public health. We manage flu outbreaks in long-term care on annual basis. We run exercises for pandemic preparation on annual basis. So there are many things that are in common between the two. What we learned on top of all this is the way we can respond to something new. So there are protocols to respond to them. However, you really have to go through the course to figure it out. For example, you look in how long the virus will survive on surfaces. We cannot know it unless we test it, and unless we test it in different studies. And we have to approach it with the most conservative approach first, then loosen the restrictions. When you look at the general management of the outbreak in the community, you go with mitigation first, then reopening stages, and you move from one activity to the other with the order to the least restriction or the least risky.
Right.
So those are in common with the protocols that we know. However, you really have to apply it for the new virus in every step. What's common between them? Both of them are viruses. They're droplet spread, so cough or touching a surface that somebody else who infected had touched before. What's difference? Again, the difference between the two could be in a way the incubation period. The flu is 2 days, For COVID, it's 14 days. That changes the management of many aspects of it, and it's not, it's a trade-off. Sometimes it's useful more practical to manage the situation, sometimes it's not. I can dive in detail with many aspects of this I'm sure you have many questions related to this.
Well, one of the things too that's interesting to me between Spanish flu and COVID-19 is that many of the preventative and treatment options are the same. People were being asked to isolate, people were being asked to wear masks, and there really wasn't a cure for the Spanish flu, just rest and a lot of hope and prayer. And we don't have a cure for COVID-19 either, and we're wearing masks and we're trying to isolate if we feel sick and keep our distance and try to prevent the spread. But one of the advantages I think that we have with COVID-19 is the developments in medical and scientific technology so that we can identify things. One of the things that really blew me away when we were doing research was that in 1918 with the Spanish flu, they didn't have microscopes that were powerful enough to see it. They genuinely didn't know what they were dealing with. With those changes with the medical technology, I would imagine as a doctor, it's much more comforting that you can look at what is actually causing the infection. You can talk to colleagues and work together.
You really touched base on a couple of good points there. Indeed, people didn't know what viruses are until 1946, before medicine considered them either a poison or they didn't know what it is. There isn't enough technology or microscope that they can see it. And when they identified it, they assumed it was life for a period of time until a gentleman with the name of Whitney Stanley won a Nobel Prize in 1946 to classify viruses as non-organism. They're not alive, because the definition of life is certain criteria need to be met, whether the organism grows, consumes oxygen, consumes food, produces energy, metabolize, responds to stimuli, replicate on its own. Viruses don't do any one of these things. They don't grow, they don't respond to stimuli. They're very similar to a hair on our head. If you put it on a table, it's not going to grow, it's not going to do anything. And for the viruses, they get destroyed by time after a period of time. For COVID, 2-3 days maximum, sometimes less on surfaces. They only do one thing that's very similar to life: replicate using genetic material from another organism. Okay. So they need our cells to replicate. And this is really key in the management of the outbreak, because if we know this substance does not have wings and legs to jump on us, all we need to do is to be careful with washing our hands and not touching our face and not having a conversation without a mask. So with that notion, before 46, at the time of the Spanish flu, people didn't know what it is. So prayer probably was the most effective one, and because if people believe in prayer and have comfort with it, that's a benefit. The COVID-19 does not have treatment at this point. There are some experimental treatments that might reduce the complications, which is great. The advancement in technology in ICU in general, with providing all the support that there is, this is a main difference between that time and this time. The fact that at that time there was war, it really reduced the ability to provide much to many people. You look at other differences, communication. At this point, we have communication that's superior, way superior to 100 years ago. People disseminate information in a timely fashion, and even in naming the virus. For us, it was named within a few weeks, not because we didn't communicate. However, it takes process and certain organization, World Health Organization, to name it. At that time, with the Spanish flu, there was a different name in different countries. Spanish flu was, it's a historical fact that during the war, Spain was neutral. It didn't participate in the war. So any country that participated in the war, they reduced their census fatality rate.
Right.
So Spain didn't and reported appropriately, so the rate was way higher. And that's where the Spanish flu name came from, because Spain got hit really hard according to the census. However, in reality, it was all the same. So that's communication is, again, it's on our side to be able to disseminate information that's necessary for the management of the outbreak and ensuring this pandemic is hopefully put in and with a vaccine down the road.
Wow, you've actually brought two new questions to my mind with what you've just said. Although I also want to say it's really reassuring to hear that this is the bread and butter of public health. You prepare for this. One, and this is a very layperson question, but a viral infection versus a bacterial infection, and why can't we just use antibiotics?
So antibiotic, the word itself, antibio, anti-life, against life. Right. So by definition, antibiotics have different classes, but some of them interfere with the metabolism of the bacteria or with different functions in a living cell, bacteria. As I just mentioned, viruses are not alive. So these drugs don't do a thing to a hair sitting on the table,
right?
Which is similar. It's a biological substance. There are drugs that would affect viruses. For example, Tamiflu is the known name for treating influenza. However, it's really specific to certain viruses, and it does not affect COVID-19.
That's unfortunate. One of the things that came out of the Spanish flu in 1919, the federal government created a national public health agency, and local papers here lauded the initiative and talked about how the lack of uniform communication made things worse during the Spanish flu. So they were even aware of it at the time. I would imagine you're in pretty constant contact with your colleagues throughout the province and potentially even on a national level with something like this.
Communication is key in emergencies. It is the cornerstone to appropriate response or less than optimal response. In any item we deal with in the health unit or provincially or at the federal level, if it's not communicated to the public in timely fashion, it might not achieve its goal if the item itself is related to information to be disseminated. And even if it's not related to dissemination of information, the lack of knowledge does not build trust in the public and the establishment. So down the road, if there is an item like recommendation that people need to hear and follow, and they don't have the appropriate trust in the establishment, it really is over but for the shouting to give that recommendation. And I can give concrete examples. We ask people who are diagnosed with COVID to isolate for 14 days. In Grey Bruce, and I can attest for it firsthand, there are many pillars to the response here, and they have been operating in an optimal way that when people hear from public health that you need to isolate for 14 days, universally they do. There are a couple incidents where there is mental illness or something, but we can support in those occasions. 2 days ago, the report from the UK came out about only 11%, around 10%, 1 in 10, would complete the 14 days isolation.
Wow.
And I cannot really judge what happens there, but more or less it goes back to communication. Mm-hmm. If people earned, or if the establishment earned the trust from the public, and the media has been very effective, like here in Grey Bruce, in delivering the message in a timely fashion, putting the information in the hand of the public to do the right thing to protect themselves, their family, and community. When you see the political system and local political leaders committed to health, committed policies, is a concept that's very important, and here it has been crystallizing in many ways, and I can give examples about them. You look at the other pillars: public health, robust recommendation and communication, the public heavy lifting. The public has been engaged, concerned, not afraid. And risk communication, you observe where the public is on the scale between, I don't care, to I am frightened. And the happy medium, I am concerned and engaged and I want to do something. So you put all these things together, when they operate, you would find optimal response to the emergency. And the relatively positive position we have in Grey Bruce, currently 0 deaths over the past 5 months. I can see the direct relationship between the two, communication and good results.
That's really interesting. I was actually just going to ask a question, and I know you've been asked this by Toronto reporters and things lately about what makes Grey Bruce's response to COVID different, not only than other places, but during the Spanish flu epidemic, mortality and morbidity rates were about the same here as they were everywhere else in Canada. But we have been working hard and been, in many ways, fortunate to, thus far, not experience the same kind of infection rates that they have elsewhere in the province. And I think public health communication strategies have definitely been very effective. Is there anything else that you think locally has made people kind of get it more?
Good question. And it's like the way I see it on a daily basis for the past 7-8 months. There are 5 pillars in Grey Bruce that have been very effective in making this happen. And if we can step back and look at the situation here in the Spanish flu, like you rightly said, that the rate was high, similar to anywhere else. The Spanish flu claimed around 50 million people worldwide. And the reproductive rate, that's the technical epidemiological number, indicates the number of people infected from one person.
Okay.
So each person would infect 2 to 3. That's the Spanish flu reproductive rate. COVID reproductive rate is 2 to 3. It's identical. Okay. So we should have seen very similar results here. And you look at Grey Bruce, we have the public engagement, as I mentioned. That's one of the pillars: public health recommendation, local political commitment to health. The media, as I mentioned. The 5th one is local businesses and community partners, and every organization really supported, whether it's Bruce Power, Chapman's Ice Cream, providing PPEs, sanitizer, or smaller businesses. And the 6th pillar that we have not utilized yet is the healthcare system. The hospitals, we had couple hospitalization, so that system has not challenged, and there have been our insurance policy. Right. Similar to the insurance policy you buy on your auto or home. You buy it and you hope you will never use it, which is a good day. Yeah. There has been testing, supporting the system with testing. Healthcare providers did an amazing job in Grey Bruce. So again, you look, what's unique about us comparing to other areas? We have the same geography and demography to neighboring counties, right? We have the same support from the province, which has been optimal. By the way, it has been a privilege to actually practice public health in Ontario. And as a medical officer of health, I should qualify that or quantify it. The position is apartisan, and I am apartisan. But truly, you look at the support we received from the government, it has been tremendous. So you put all these things together, that's what I see has provided us with this.
Okay. I came across an interesting anecdote about local doctors during the Spanish flu, and I think that you can probably relate really well to this. They were talking about it, and the doctors were saying that for weeks and weeks, from October to December 1918, they were getting 2-3 hours of sleep a night, 10 plus cups of coffee a day. And of course, in that time, they did house calls and they'd go out to one farm, but by the time they came back, they'd have stopped at 10 to 30 farms because people would flag the doctor down. I'm guessing your days have been equally busy and challenging since this started.
Guilty as charged. Guilty as charged, Your Honor. I would attribute it to two things probably, adrenaline and purpose. Since mid-March, I worked an average of 13, 14 hours a day. No weekends. It slowed down in July and early August, and with school reopening, it ramped up. Again, now, although it's a second wave, but there is more experience with the way we're doing business with this pandemic. We know exactly what we need to do, and we know what worked. In March and April, you go back, and that's probably touch base on the first question you said, what did you learn? In March and April, we had to have the mitigation period, shut everything down, because we put the measures in place, but we don't know if this is going to be sufficient or not. And when you control it, you start reopening as fast as you can, as long as safe. And you observe and monitor and see what would work. And we know right now we probably don't need a full shutdown, as long as people do certain recommendations. So yes, it requires a lot of work, but it's not just a physician. In the health unit, we have around 120 professionals, and I know they've been burning the candle at both ends. Contact tracers do an amazing job. Contact tracing, most people think, is just a phone call. It's a complex protocols that need to be deployed in a careful way, in a supportive way to the client, whether it's delivering that diagnosis to the person and walking them through what this means and how they can protect themselves, take care of themselves. And at the same time, evaluate information, where they have been, who they have met with, and doing a risk assessment for each one of these individuals, then calling them. So each person would generate a number of people, and each one of this group would receive at least 14 calls, if not more. And to assess reliability, cross-examine the information, trace it. It's an investigation. It's a truly very complex investigation. So all these people, going back to working long hours, have been, and I know whether it's local political leaders or small businesses or any individual in the community had invested effort in making this happen, and that's why we have the good results we do.
Well, I would like to thank you personally for the town halls that you've put on. In the spring, I was redeployed in long-term care, so we did several town halls, which was helpful to me, particularly as a newbie in that environment. And then before we opened, you had a town hall with nonprofits in the area that was very helpful. And then as a parent, it was when my kids went back to school. So I think your communication has been really fantastic, and I really appreciate it, because it keeps me in that middle ground where I'm concerned but not frightened. And I'm sure I'm not the only person in this area. Thank you.
Glad to be of service. We're glad to be of service.
Fantastic. Well, thank you so much for joining us today. I hope on so many levels that things resolve soon and that you can get back to having a nice full night's sleep and that we can put this in our history books. But thank you again for joining us today.
Thank you for having me.
Call the Rogers TV viewer response line, email us, or connect with us on social media.
What kind of show do you want to see on Rogers TV? What interests you? Log on to rogerstv.com, fill out a show proposal, and tell us about your segment idea. We want to know what you want to see. Rogers TV, only on Rogers.
After a night out with your friends, not having a plan for a safe ride home can leave you in a bad spot. You could end up riding in a police car, an ambulance, or